Dear friends, at the outset, let me thank the organizers and Karnataka State Ophthalmological Society for giving me this opportunity to present the Dr. K. Bhujanga Shetty Oreation. Dr. Bhujanga Shetty is a doyen in the field of ophthalmology, and single-handedly he built the Narayana Nethralaya that has risen as an institute of international repute. Throughout his career, he stressed the importance of quality clinical care, research, and teaching as important founding principles. He has recently been named a legend in ophthalmology by Times of India in 2018. I would again like to thank the Karnataka State Ophthalmological Society for having given me this opportunity. I would like to dwell briefly upon the evolution of vitreoretinal surgery with special emphasis on internal tamponading agents, about which I have special interest. It all started with identifying retinal breaks in eyes with retinal detachment and trying to relate the two. And this was identified within 2 years of the introduction of direct ophthalmoscope by Helmholtz and Ruet with indirect ophthalmoscope by Ruet. But people didn't understand the relationship between the two, and they thought it is a detachment which caused the break. It was gone in who related the cause and effect relationship of the retinal break versus the retinal detachment. A lot of credit for the present day vitreoretinal practice goes to Dr. Charles Keepens in Boston, who popularized binocular indirect ophthalmoscopy with indented examination. He developed several techniques, some of which probably are historical importance, but many of which we incorporate in our daily practice. He developed the technique of implant scleral buckling technique, open sky vitrectomy, etc. Most importantly, he has trained an army of retinal surgeons, stressing throughout on the diligence and meticulousness to detail. Coming to retinal reattachment surgeries, the initial attempts were always external in nature because vitrectomy was not in vogue at the time. Indenting the eye wall to approximate the retina to the retinal pigment epithelium was what was attempted. The initial procedures was scleral resection, as was done by Mueller, Linder, and Chaplin. And rapidly it was replaced by indentation techniques without scleral resection using exogenous material. Jesse tried just simple gauze pad, and this was rapidly replaced by more tolerant materials because gauze tends to get infected over a period of time. Custodies developed the local plumb, and we now have a plethora of scleral buckling elements, both for localized implant and for encerclage. So the materials that form the scleral buckling elements have also developed over a period of time, from polyvinyl, polyester, etc., all the way to the present generation of solid silicon, which has stood the test of time. The next important step was how to create an adhesion between the retina and the underlying retinal pigment epithelium and choroid around the retinal break so that the break can be sealed once and for all. The initial attempts were by using cautery across the sclera. As you can well understand, the entire sclera is damaged and necrotic because of the cautery procedure. Similarly, full thickness scleral diathermy was also found to be very dangerous for the sclera, and hence Keepens developed the scleral implant technique wherein the scleral bed is dissected and diathermy is applied within the bed. With the advent of cryopexy, diathermy has fallen into disrepute, and at this point of time, perhaps diathermy is not even available. Laser photocoagulation has also come into vogue in a big way, both for use in the clinic, externally, and during vitreous surgery. This is a short video of an implant technique of Dr. Charles Keepens, performed by my guru, Dr. S. Badrinath, way back in 1982. I will skip the more mundane steps and go to the important step of the scleral dissection being made. You can see the incision being made with the Deshaber knife, and then the flaps are raised and the bed is dissected to the extent that is required based upon what implant is chosen. And then diathermy is applied within the bed at uniform intervals. And since diathermy causes more stronger adhesion than cryo, you don't have to make confluent burns. This kind of application is more than enough within the bed to cause adhesion. And then the mattress switches are passed and the scleral buckle is placed underneath the mattress switches. And encerclage is done as a routine and drainage is done as a routine. So basically this video shows us a technique which was adopted in the past for many years before it was supplanted by the explant technique and cryopixy. As I said, this is of historical importance and nobody does it these days. Internal approach to fix the retina was rapidly thought to be necessary because external approach cannot correct all kinds of detachments. The bands in the vitreous keep the retina detached despite a buckle, and hence Deutschmann tried to cut the bands by just using a knife penetrating through the aura. You can understand what the repercussions of this step would have been. Subsequently, people did attempt an open sky vitrectomy, and Hal Freeman even used a more controlled cutting off of the bands by using a scissors introduced to the pars plana and used inflated balloons under indirect ophthalmoscopic control. All this, of course, is of historical importance because of one man, Robert Markman. He has revolutionized the way we can manage vitreoretinal diseases. He has invented the vitrectomy system, and his initial tool is the vitreous infusion suction cutter, which is a multifunction probe of almost 18 gauge size, gigantic by today's standards. But it served the purpose and initiated us into the art of vitreoretinal surgery. There were other clones that were developed rapidly by Dowers, the roto extractor, and Payment's vitrophage. These were replaced by the Acutome system by Conor O'Malley, and this is a split function system. This perhaps is another important landmark in the development of vitreoretinal surgery, and the present day cutters are all clones of this Acutome system, be it 20 gauge cutters or 23 gauge cutters or 27 gauge cutters. We rely heavily upon the multifunction, we rely heavily upon the split port system. Although this vitrectomy approach could correct a majority of disorders which could not be attended to before the advent of vitrectomy, we still had difficulty in reattaching retina, such as in a giant retinal tear. People have tried injecting gas and positioning the head to unroll the flap, but vitrectomy followed by prone fluid air exchange has caught the imagination of the ophthalmologist. Prone fluid air exchange could be done in a controlled fashion using a striker's frame and a rotating table, which is not always available. And since we didn't have it, we had to innovate. An innovation we did. With the help of an anesthetist, the patient could be strapped to the trolley top, and then halfway through surgery, the head end of the patient is still kept under sterile drapes and turned in a prone position. This step is very, very vital in its planning requirement. Otherwise, it can result in disastrous consequences. And once the patient is in the prone position, the surgeon goes on a surgeon creeper, and does fluid air exchange using indirect ophthalmoscope through the pars plana using 30 gauge needles. And once the retina is reattached, we turn the patient back in supine position and inject oil in the air-filled eye. I had an opportunity to do 2 such giant retinal tears before. Mercifully, Dr. Stanley Chang invented perfluorocarbon liquids, and then now the giant retinal tear surgery is child's play. The same holds good for the treatment of choroidal neovascular membranes, which is now currently done with intravitreal injections even by general ophthalmologist. But in the pre-anti-VEGF era and pre-PDT era, treatment of these were extremely difficult. And very often we ended up not offering them any treatment. Although some people even directly destroyed the macula along with the CNVM with photocoagulation. In this video, I show the submacular surgery which was sharply in vogue because of the inventions of Matthew Thomas, wherein he performed a vitrectomy, created a retinotomy, and detached the macula using DSS, and under the blood, we use a subretinal spatula to separate the choroidal neovascular membrane both from the undersurface of the retina and from the retinal pigment epithelium. Once the membrane is well mobilized, it is held with forceps and removed. As you can understand, since the membrane is plucked, it has got to be in front of the RPE in order not to damage significant areas of retinal pigment epithelium. And hence, this is applicable only for type 2 membranes where the membrane is entirely present in front of the RPE. So the two cases which I'm showing here, not the videos but photographs, are of young people with idiopathic membranes which could be elegantly removed using this technique. And both had, fortunately for me, a good surgical result postoperatively. This retinotomy need not be treated and can be left untreated with fluid air exchange. These are the two eyes of the patients with idiopathic membranes, both of whom have recovered very good vision subsequent to the surgery, courtesy a healthy underlying RPE. Obviously, this is all of historical importance with the advent of anti-VEGF therapy. Coming to internal tamponading agents, Edward Norton introduced gases into vitreoretinal surgery, and we still use SF6 and C3 quite routinely. Stanley Chang introduced perfluorocarbon liquids, which, as I alluded to, has revolutionized the care of complex detachments such as giant retinal tear, retinotomies, retinectomies, etc. People needed long-term silicone internal tamponading, which was provided by Paul Sibis. John Scott from UK used silicone oil as an instrument, not as a tamponading agent, but it was Jovanovic which combined the virtues of vitrectomy and silicone oil by doing vitrectomy with silicone oil being used only as a tamponading agent. Even currently, we use this combination for many complex detachments of retina. But are they ideal? Neither gases nor silicone oils fulfill the features of an ideal substitute. An ideal vitreous substitute should be easy to inject and easy to remove, or at least there should be no need to remove. We should be able to titrate the length of longevity in the eye. It should be optically clear so that patient can see postoperatively, and we can also do laser, etc. Postoperatively. It should be able to obviously support the retina and permit retinal reattachment. It should have no mechanical or toxic effects on the retina and should not cause cataract or glaucoma. Ideally, there should be no need for special posture and there should be no restriction on air travel. Now, none of the substitutes we have currently fulfill these criteria. So there's obviously need to try and identify newer substitutes. Our foray into field of tamponading agents was kicked off by this collaborative effort between myself, Professor Su Zinni, who is the driving force behind this whole project, and Professor Lo Sin-chun, who is a polymer scientist of repute, supported by a good team of scientists. And we zoomed down upon smart hydrogels, which are thermoreversible polymers. They are liquid in cool temperature, and when they touch the human eye, they become a gel. So they're easy to inject, but in the eye, they become a gel. And the transition temperature is tunable. These are transparent, they are biodegradable, hence no need to remove, and obviously easy to inject when they are cold. So the product we chose is a patented product, the patent of Professor Sin-jun, and is a tri-block polymer containing polyethylene glycol, polypropylene glycol, polycaprolactone. It is thermosensitive, optically clear, with a refractive index of 1.34 and is entirely biodegradable in a matter of about 2 to 3 months. At about 16.3 degrees, there's a transition between salt to liquid, salt to gel, and it has got a viscosity which is much higher than silicone oil. The current tamponading agents function by flotation force and buoyancy, while the hydrogel acts by swelling counterforce, and hence potentially it can tamponade inferior breaks as well, and perhaps does not need special posturing. As you can see, the surface tension of this gel is nearly 10 times that of silicone oil at 37 degrees centigrade temperature. This is the initial experiment in the rabbit eyes, wherein we performed a vitrectomy. This is triamcinolone, which is used to facilitate vitreous detachment, And in rabbits, you know that medullary ray has a strong attachment of residual vitreous, so you cannot remove the entire vitreous from the vitreous cavity. Following vitrectomy, we're injecting the transparent gel. You can see the injection being done to a 25 gauge cannula very comfortably, and it's a absolutely clear, optically clear gel. And following the surgery, we evaluated these rabbits at periodic intervals, and it has not shown any toxic effect to the retina. And evaluate on OCT, you can see all the layers intact, and evaluated histopathologically also, you can make out all the retinal layers are intact, compared to the unoperated eye on top and an operated control where no gel was injected. Once we were encouraged by these preliminary results, we chose to perform surgeries on non-human primates, wherein we did a retinotomy, detached the retina, and then created a retinal break, which was sealed with endolaser following a reattachment and fluid exchange. Following surgery, as you can see, evaluation on fluorescein angiography, autofluorescence, and OCT showed that the macula is perfectly healthy and the retina does not show any signs of toxicity. The same were confirmed by electroretinography, wherein both on scotopic ERG and photopic ERG, the waves are well maintained. We also found something interesting in the rabbit eye. Following the hydrogel injection, when the eye was removed nearly 6 months later, we found something mimicking a vitreous gel. We were really puzzled by what exactly this material is, because it's almost as if we have not done a vitrectomy. It's very, very sticky. As you can see, it's being cut with a knife. Well, contrast this with another eye where vitrectomy was done, but no gel was injected. You can see that this material can be easily sucked with a cannula compared to what I showed you earlier. So this material was then studied. The NMR studies of this material showed that there was definitely no residual hydrogel, which is the first thing we suspected. None of these segments of pure hydrogel, ethylene glycol, polylactone, etc., were not found in this material. And mass spectroscopy of this material showed that the proteins are similar to the native vitreous gel in terms of the types of collagen, non-collagen structural protein, hyaluronic acid binding proteins, heparin, and chondroitin sulfate proteoglycans. So we really don't know what exactly has happened, but it looks as if a vitreous-like material is being generated as a reaction to the presence of the hydrogel. If this were true and it is consistent, it will be a very good boon to offer, because this artificial vitreous can actually support the retina permanently long after the hydrogel has been removed from the eye by biodegradation. In monkey eyes, we could not replicate this part of the study. So the preliminary results were reported in the Nature Biomedical Engineering, and further studies are on to try and refine this product. So the lessons from history are that change is expected, and major innovations come once in a while, but minor improvements are equally important. One should adapt to the change, but also understand that not everything new is good. So before we adapt, we have to assess whether it is really right to change or not. For this, the golden mean of Aristotle comes in handy. Herein, we don't go to any extremes. We try to have a balanced view, an unbiased view of anything new development, and then try to incorporate it into our routine practice. But we don't stumble because we try to incorporate them too soon into practice before it has been tested well. So in conclusion, vitreoretinal surgery has come a long way since the introduction of closed vitrectomy by Robert Markham. Many hitherto untreatable conditions have fallen to the vitreoretinal surgeon's knife. But the absence of a good vitreous replacement still remains an irritant. And we hope that the thermoreversible hydrogels that we alluded to may hold a promise as a future vitreous substitute. Thank you very much for your attention.